Hi, and welcome back to the second portion of my seventh neuronursing webinar. I'm Lauren Daniels, and I'm the specialty practice leader for neurosciences ICU at OHSU in Portland, Oregon. This section, I'll be discussing the distal transradial angiography, or when we need to visualize the vessels in the brain, and we choose to do that through the artery in the wrist. So to start off this talk, I want to just declare that this article right here is where the bulk of my information for this talk came from. So unless otherwise noted, this is the source for the content that I'm speaking to. So in talking about why the distal radial approach is advantageous for the patient, there's about 5 or 6 main themes that we could discuss. We already know that patients really appreciate the transradial artery approach when compared to the typical femoral artery stick for a number of reasons that we'll get to later in the talk when we recap a little bit and summarize. But why distal radial specifically? And one of the reasons is because of where this artery is located, there's a potential for faster hemostasis. So after we've used this artery for access point for either visualization or intervention within the brain vasculature, reestablishing hemostasis to that arterial puncture can possibly be quicker and simpler with this approach. The reason for that being because of the way the artery passes through the carpal bones rather than being superficial over the top of the wrist. The carpal bones provide a little bit of compression, a little bit of pressure on the artery, which can facilitate that hemostasis to an extent. And then the other thing, which I think is the most important reason why this is, for some people, a preferable approach, is that there is less risk of hand ischemia. Most people value their hands more than potentially other body parts. Hands are very important for a lot of reasons. And so if we have an approach that affords a higher level of safety in protecting that resource to a person, then obviously that's a pretty significant advantage. So when I'm talking about distal radial, I'm going to show you a picture of what that means, but to really simplify it, as you can see in this picture, it's that space between the two tendons on the proximal aspect of the thumb where it connects to the wrist. That area is called the anatomical snuff box. So taking a more zoomed in look at the anatomy in this area, let's take a look at this picture on the right first. So here you can see where the distal radial artery puncture site is, and you can also kind of see how it approximates with the carpals. So see here how it is actually a branch separate from this palmar circulation here. So that's the element that gives us that added level of protection against hand ischemia and makes itself a really important point. So in this picture, you can see here where the actual puncture would be and the fact that it's excluded from that important circulation there. Whereas the traditional or proximal transradial artery approach right here would, if it spasmed or clotted or stenosed, or became damaged, would affect that entire distribution. So that's a pretty important point. Another reason why distal radial is great is because it provides the potential for greater comfort. And when I say greater comfort, I'm not just talking about the patient, I'm also talking about the interventionalist or the surgeon. So talking about the patient first, you can see in this picture right here that this hand is in a very relaxed, normal anatomical position. It's not forced, it's not flexed, it's not strapped to an arterial line board. I think we've all seen what it looks like when a patient gets an A line, and the transradial artery approach in an interventional suite is a pretty similar stabilization setup. This is very natural to the body ergonomically. And then speaking of ergonomics, the way the surgeon stands in correlation to the patient for the transradial artery approach gives them a lot more of a natural body position when they're working and maneuvering. So it's great for both of them. The other thing that's interesting is the way the catheter enters into the artery because of the way it's the natural trajectory of the artery. It has a curvilinear trajectory to it, so it's got some curve to it. And what that does is it has an ability or a tendency to stabilize the catheter more than their traditional TR band. So what surgeons or interventionalists will report is that they can perform several passes through this sheath without it migrating or pulling with really minimal retention. So sometimes just a tegaderm over it, as you can see in this picture, they're probably getting ready to do that. The other really nice thing that I like about distal radial as a nurse is that these patients don't come up with that groin lay flat restriction where they have to stay flat. And we always know that sometimes these patients that get an angiogram aren't your fully intact patient. And so having them lay flat provides a whole complicated matter of issues that we sometimes have to deal with. Sometimes ICP issues, which, that's not ideal for. So when you have a patient that doesn't have that lay flat restriction because of a groin angiopuncture, super, super nice. Similarities to the traditional TR. So you can see in this picture right here, you can see the traditional TR band right here. It's worn on the wrist, kind of like a watch. Both sites, distal TR and proximal TR, are really easily compressible for hemostasis. So if the dressing or if the band fails, it's very simple and straightforward to apply manual pressure. You can apply manual pressure to a groin, but it's obviously not going to be as straightforward as something as visually obvious as a wrist. There is a slight potential for easier hematoma formation in the snuff box just because of the compartment shape. But I think with vigilant assessment and being attuned to this possibility, the risk isn't marked or it's not weighted enough to be a contraindication to the approach, especially given the advantages. So obviously, I would say most people would express a greater level of satisfaction having a poke in their wrist rather than their groin. The other thing too is that it's a lot easier to visualize. Most people have their arms out and about, but it's a little bit disruptive when we have to go in and check a patient's groin every 15 minutes, during the initial recovery phase. Patients who have a poke in their wrist tend to recover a lot quicker. There is also a potential for decreased radiation exposure and decreased cost. So overall, regardless of distal or traditional TR approach, it's a great option. More patient considerations. So these ones are a little bit more about how you take care of that patient that has had this access. So we want to put the pulse ox on the ipsilateral side thumb. And the reason for that is because looking at the quality of the pleth wave is going to give us kind of a approximator of perfusion to that area. And so that's kind of indirectly going to speak to us about quality of the perfusion to that limb as a whole. Window here. So that's the first thing we want to do is make sure we have a pulse ox on here and that it's actually hooked up and that we're watching the waveform. Your facility, especially ours, has very strict guidelines about what intervals we check vital signs, do vascular checks and neuro exams. So typically it's Q15 times 4, Q30 times 2, et cetera, et cetera. So know what those are and make sure that you're both abiding by them and documenting them on a schedule. There's a regulatory element. The other thing that I personally in my own practice like to do is teach a patient what to do in case there's an emergency, because if the patient is appropriate and developmentally and in terms of health literacy, I like to teach them how to apply flat pressure in case there's bleeding, because that can make a huge difference between, if I'm stuck in a neighboring room and their call light's on, whether or not they're pulsatile bleeding or holding pressure. If it's possible to teach them to do that, I like to do that. Specific risks that are related to distal transradial artery are going to be some patients will verbalize transient thumb numbness, and then there is this textbook sporadic wrist ache, which I know patients with narrower wrists are more prone to get based on the literature. I would educate the patient on both of these to let us know. And even though they are known side effects, any type of numbness or tingling, I would still report to the interventionalist. Even though it's slightly expected in certain cases, I would still report that up and let them be aware and decide. So getting into a little bit more detail about things that we should escalate. let's talk about notify the provider if. So like we talked about numbness or tingling, let them know. If that pleth wave gets dampened, let them know. If there's a new focal neuro assessment, let them know, because as we know, patients who are having angiography are at a stroke risk. That's just part of the deal. If there's changes in your neurovascular assessment, so that's going to be your poor cap refill, cool extremity, paleness. Obviously, if there's any bleeding, even if you reinflate the band, like even if you reinflate the air bladder and it stops it, you still need to let the proceduralist know that the bleeding did occur. And then the other thing that I like to do is to measure bilaterally. Sometimes it's hard to tell when a hematoma is developing when you're only looking at one arm, but comparing bilaterally is kind of like a life hack or a pro tip that usually helps me figure out pretty quickly with some objective certainty when something's going wrong. And then the other thing too is this is pretty minimally invasive, so the patient shouldn't be reporting a whole lot of pain. So if they are, I would report that too. So I would report it either way: numbness, so lack of feeling, or if they're having pain that seems, not on par with what you would usually have from an angiopuncture, that's definitely reportable. So let's take a minute and look at what the actual band looks like for the distal TR, because there is a special disposable for this. You can use a traditional TR for this, but especially at our facility, we are getting the specific band for the distal approach. So let's take a minute and look at that, see what it looks like, and then we will be about wrapped up.
My name is Rob Rowley, Director of Training and Education for Merit Medical. Welcome to a virtual in-service for Prelude Sync Distal Radial Compression Device. The Prelude Sync Distal Radial Compression Device is used to gain and maintain hemostasis of the distal radial artery. It has a soft wristband and thumb saddle strap with secure hook and loop fasteners. The band delivers adjustable compression of the puncture site with an inflatable balloon and a check valve for easy inflation and deflation with a syringe. A clear curved backer plate provides optimal visualization of the puncture site and ease of placement. For a large patient wrist or hand, you may add the extension band prior to placing the Prelude Sync Distal. Aspirate the sheath and withdraw the sheath back approximately 2 to 3 centimeters. Place the center of the crosshairs approximately 1 to 2 millimeters proximal to the skin puncture site. Place the band on the hand and wrist with band 1 on the little finger side, band 2 on the thumb side, and band 3 facing up toward the thumb. Fasten band 1 and 2 tightly around the wrist, then place band 3 around the saddle of the thumb without any slack. If the sheath is in the way of securing band number 3, then band number 3 may be secured after removal of sheath. Fill the included syringe with 10 mils of air. Maximum balloon fill volume is 10 mils. Engage the syringe into the valve on the top of the device. Slowly inflate the balloon with air while simultaneously removing the sheath. Once the sheath is completely removed, continue to inject air until bleeding has stopped. While inflating, maintain pressure on the syringe plunger to avoid any inadvertent release of air. Slowly withdraw air from the balloon until there is a flash or a pulse is observed from the access site. Once oozing is observed, re-inject air into the balloon until hemostasis is achieved. If bleeding is observed at any time, inject additional air until bleeding stops and hemostasis is achieved. It is important not to exceed the max fill volume of 10 mils. Remove the syringe. The patient should be able to move their hand or wrist freely without any bleeding. Per hospital protocol, a small amount of air, such as 1 to 2 mils, can be removed every 15 minutes until hemostasis is achieved. Ensure a negative is not pulled on the balloon. Complete hemostasis time may differ according to patient's condition, anticoagulant dosage, and size of puncture site. If bleeding is present, inject air until bleeding stops and patent hemostasis is achieved. Wait a sufficient amount of time and repeat the device deflation and removal instructions. Once the air is removed and hemostasis is confirmed, carefully remove the Prelude Distal Sync and place a sterile dressing over the site per hospital protocol. For any additional questions, please contact Merit's clinical support team or your local Merit representative.
So let's talk about the things we need to educate our patient after they've had this procedure, and how the post-procedural restrictions kind of they crescendo as time goes from 24 hours to 7 days. So at 24 hours, for that first 24 hours, they're not allowed to lift more than 1 pound with the affected side. They shouldn't be excessively moving the wrist. So it's okay to, give it a little bit of movement, but nothing that reaches the stretches of the ROM. They should keep it really moderate and conservative movement, no vigorous exercise. Some people will say no blood pressure on the affected side for 48 hours, but especially not during the first 24 hours. But a lot of people recommend that restriction all the way up to 48 hours. No forceful movement of that arm for 48 hours. So no, that would be like driving, something like that. Don't do that. They still can't lift that 1 pound. And we want to keep that dressing intact for the first couple of days. So no wetting the dressing. So the restrictions liberalize, but continue until day 7. So until day 7, still no excessive pushing or pulling with that arm. So that could be examples of things like golfing, fishing, mowing, carrying a baby carrier, groceries, things like that. No submerging or swimming yet. So by this point, it's definitely fine to, shower or gently wash, but don't, no bathtubs, pools, jacuzzis, things like that. Just treat it like a really small incision. This person at day 7, especially if they had the angiogram for cardiac reasons, will probably be asking when they can return to their previous level of activity, especially if they have like a cardiac rehab program that they need to adhere to. The direction for that is going to be they're okay to resume, but with caution. So they need to still maintain reverence over the wrist and the direction for how quickly they can resume and how much they can resume should ultimately come from the physician. So that wraps up this conversation. These are my references for both portions of the talk, the TR band portion and the laser interstitial therapy portion. If you have any questions or have any ideas for future segments, please email me on daniello@ohsu.edu. Thanks.